Ma'am, should I start? Can you see the PPT?
Yeah, you can start.
Yeah. Good morning, everyone. My name is Dr. Jaisinha. I'm a fellow in rheumatology at CRD. So my case is a 38-year-old female Hindu teacher resident of Satara, examined on 1st of March 2024. Came with the chief complaints of swelling and partial closure of the eyes since 7 years, difficulty in swallowing since 7 years, difficulty in getting up from seated position since 6 years, skin tightening over the hands since 1 year, difficulty in raising the hand above the head since 1 year, and difficulty in eating and unbuttoning of clothes since 8 months. The swelling around the eyes with partial closure of both the eyelids was insidious in onset and gradually progressive. Erythematous rash around both the eyes were present, not associated with any itching or pain. Swelling of the eyelids were reduced with medication given at that time. However, partial closure of the right eye still persisted while the left eye was resolved. Difficulty in swallowing since 2017, insidious and gradually progressive, equal on both liquids and solids. No sudden bouts of cough, changes in voice, nasal regurgitation. Occasional episode of oral water rash was present. Symptoms were completely resolved by 2018 with medications. Difficulty in getting up from seated position and climbing stairs since 2018. Insidious and gradually progressive. Symmetrical involvement of lower limbs. Continued teaching with support, but later needed complete support for walking. The thighs were painful to touch. Muscle weakness and fatigue on exertion. No joint pain, swelling, sensory involvement, or bowel bladder involvement. Extended to the proximal muscles of the upper limb by 2023 with the similar onset and other complaints. The skin tightening around the hands has been present since 2023, insidious and gradually progressive, symmetrical in both the arms, distal to the elbow. Rashes over the knuckles were present. No bluish discoloration of the skin, pain, digital ulcers or scars were present. Incomplete fish formation was there. There was difficulty in eating food, unbuttoning of clothes since the past 4 to 8 months. Insidious and gradually progressive. No sensory involvement or joint pain or swelling was present. No history of malar rash, photosensitivity, fever, breathlessness, dryness of the mouth or eyes. No lumps or swelling all over the body. There was no significant family history, no known comorbidities. Sleep, appetite, and bowel bladder habits were normal. The patient had a mixed diet, denies any addiction. The patient had a history of weight loss of 10 kgs in the past 3 years. The obstetric history, the patient's first 2 pregnancies were a first trimester abortion, but the later 2 pregnancies were delivered by LSES. Both the children are 7 years and 9 years old, respectively. Should I continue?
Yeah, can you summarize the history?
Yes, ma'am. So the patient had main complaints of swelling around both the eyelids since the past 7 years with partial closure of the eyes. Difficulty in swallowing since the past 7 years. Difficulty in getting up from seated position, skin tightening, and difficulty in raising arm above the head, as well as difficulty in eating and unbuttoning. That is, the patient had proximal muscle weakness since 2017, along with of the upper limb and the lower limb. The lower limb started in 2017 and the upper limb in 2023, with skin tightening around the hands since the past 1 year, and partial involvement of the distal muscles since the past 1 month.
Okay, so what is your thinking?
So right now, ma'am, along with the complaints of proximal muscle weakness with skin rashes, of the upper limb
Mhm.
and the lower limb. It shows typically towards dermatomyositis, since no other typical complaints were present, and the skin tightening of the skin distal to the elbow is more indicative of scleroderma or skin involvement. So further investigation needs to be done regarding the same.
Okay, and are you thinking of anything else with muscle weakness or swallowing
Mhm.
difficulty? Any differential you want to ask in their uh, history? What are you looking at? Do you have any thoughts on that?
The patient was asked whether she had any history of statin intake or any
Huh.
other drugs that could have caused the muscular weakness. She gave no other history of any drug intake.
Apart from
Apart from
statin,
that,
drugs can cause muscle weakness.
yes, ma'am. There can be uh, chloroquine, diphenylamine,
Chloroquine.
steroids. Ma'am.
Okay.
Uh, so, in the history, the patient has been non-compliant to the
And any drug
medications.
which
Has
can cause muscle weakness as well as tightness.
mm,
With tightness, are you thinking of any medicine?
ma'am, tightness is mostly due to environmental exposure or any bleomycin or similar drugs, but those history was not given by the patient.
Okay. And what are you thinking about the weight loss that she has?
And the weight loss, even though the appetite was normal, the continued weight loss since the past 3 years indicates um, chronic condition, chronic inflammatory condition. So that can be related to either uh, the muscular weakness, the generalized systemic inflammatory involvement for the same.
So, Dr. Jaisinha, what is the differential diagnosis? So, skin tightening, proximal muscle weakness,
Yes, sir. So
predominantly proximal.
the differential diagnosis based on the history is overlap connective tissue disorder with features of dermatomyositis and primary systemic sclerosis of the limited variety, or it can be the uh, MCTD, which is mixed connective tissue disorder.
Okay. All right. Is there any respiratory or cardiac complaints?
No, sir. No respiratory or cardiac complaints, no complaints of breathlessness, even on exertion, even though the patient was walking with support.
Okay. All right. And the gag reflex was present. Did you
Yes, sir.
examine that?
Yes, so the gag reflex was present. Even though she had episodes of water brash, there were no episodes of sudden bouts of cough while having the food or any nasal regurgitation or changes in the voice.
Okay. And can myositis by itself cause weight loss? Can that be a symptom?
Yes, so chronic myositis can cause weight loss due to inflammatory as well as the muscle loss.
Yeah, myositis, inflammatory myositis by itself, the symptom can be weight loss. Okay.
Yes.
Yeah, please go ahead. Ma'am, anything else that you want to ask? Shobhita ma'am?
No, I'm okay. I just wanted to tell you, Dr. Mane, that whenever you are
Yes.
taking history, you should think of all these factors rather than jumping to conclusion. And about the weight loss, I wanted to ask you whether it can be related to the swallowing. She has difficulty in swallowing. So was the eating affected because of that? Because it was
Uh,
to liquids and solids. So see, lot of times when you are presenting a autoimmune condition, you presume
um,
everything is related to autoimmune. So that should never
yes,
be
ma'am.
done. Hmm?
Yes, ma'am. So, ma'am,
Yeah.
the initial complaints of swallowing were present in 2017, but later on, following medications, it was completely resolved by 2018. That's why I didn't consider that in the
Correct.
differentials.
So we don't know what that diagnosis was.
Yes, ma'am.
Okay, fine. You can go ahead.
So on general examination, the
You
present.
wanted to complete, na?
Yes, ma'am.
Treatment history you are not presented.
Um,
Huh.
So in 2017, on initial onset, with both the eye swelling and partial closure, the patient was started on prednisolone 40 mg per day orally with the tapering dose, along with azathioprine, which was
So
initiated
here
at
you
50
have
mg
not
per day.
told us that what was the diagnosis done and investigations done.
Yes,
Why
ma'am.
was it started on steroids and azathioprine?
Okay, ma'am.
Was the diagnosis of dermatomyositis made already by somebody?
Yes, ma'am. Ma'am, I've mentioned the investigations before presentation
Later.
on the
Okay.
slide.
Fair. Fine. Fine. Fine.
So
You can continue. No problem.
yes, ma'am. So the prednisolone 40 mg along with azathioprine was started at that time. The patient was lost to follow-up for a year after that. Then in 2019, she presented again with lower limb weakness, proximal muscle weakness, for which prednisolone 40 mg per day was started on tapering dose along with methotrexate. She continued the medication for a year, but then was again lost to follow-up. In 2022, she presented with complaints of proximal muscle weakness of the upper limbs, for which again prednisolone was started along with the tapering dose, but this time mycophenolate mofetil was started. In 2023 to 2024, the patient was completely off medication on homeopathic treatment. And just before presentation to us, a month ago, the patient showed to a nearby hospital where the prednisolone 40 mg was started on a tapering dose along with MMF. On general examination, the patient presented to the OPD in a wheelchair. A history was given by the patient and her husband. She was conscious, cooperative, well-oriented to time-place person, examined in supine position, height of 172 centimeters, weight of 47.4 kgs, BMI of 16. The pulse was 70 beats per minute in the right radial artery, normal rhythm volume character. All peripheral pulses were felt, no radioradial radiofemoral delay. The BP was 106 by 74 mmHg in the right brachial artery in the supine position. Respiratory rate was 20 per minute thoraco-abdominal. Facial edema was present. No pallor, icterus, lymphadenopathy, clubbing, and cyanosis.
Was it only facial or was it around the eyelids?
Ma'am, facial and eyelids, both.
Okay. And all this general examination, what you have mentioned, do you think it has any significance with the condition you are presenting?
Ma'am, the facial edema does have a significance since she's been a chronic patient of steroid use. That's why the facial edema can be present because of that or because of the scleroderma too, which is one of the differentials. The cyanosis is an important factor of the peripheral limbs. The patient,
Why is cyanosis important?
ma'am, in case the patient is presenting with any features of Raynaud's phenomena or any.
So you have not mentioned Raynaud's anywhere. So cyanosis is not same as Raynaud's, right?
Yes, ma'am.
Hmm.
Yes, ma'am. The patient did not present with any features of Raynaud's
Is
or
clubbing
had any history
significant
of
here?
Raynaud's. Yes, ma'am.
If clubbing was present, why did
Yes,
you
ma'am.
mention clubbing? Why is it important?
Ma'am, any respiratory involvement, long-term chronic condition can
Right?
be presented with clubbing. Ma'am, COPDs, asthmas, in this specific patient, ILDs.
Okay. So again, the point I'm making here is whenever, see, we teach you to say all this by default, right? Pulse is
Yes,
so
ma'am.
much, equal on both sides. If you don't say also, we question. But also,
Yes, ma'am.
it is important whenever you are presenting where each of your finding is relevant to something else. Means BP normal. What is the significance?
Ma'am, in case of a cardiac involvement or uh, in patients of Takayasu, the BP can be different
Are
in
you
both the
thinking
limbs.
of Takayasu's here?
No, sir. No, ma'am. Not in
Then
this
why
patient.
is the BP important here?
Mm. Ma'am, the peripheral vascular involvement in patients of scleroderma.
Will the BP be high because of peripheral vascular involvement?
Mm. Yes, ma'am. Not because of peripheral vascular, but in case the patient is suspected of scleroderma, renal crisis, in that case, the
Correct.
BP will be high.
Correct. That is why you want to know. Even facial edema can be important because of that. Okay.
Yes.
Why is why is the pulse important and regularity of the pulse?
Ma'am, in the cardiac involvement in patients of scleroderma, there can be arrhythmias,
Correct.
as well as conduction
What
defects.
else? What if there was a tachycardia here?
Uh, Ma'am, similarly, the cardiac muscle involvement or uh, pericardial effusion, if it is present, then the patient will have
Good.
tachycardia and low BP.
Also, whenever the patient has significant proximal muscle weakness, overall
Yes.
endurance goes down. So when the patient walks to your clinic, even that exertion of getting out of the car and sitting on the wheelchair, you can sometimes get tachycardia.
Yes.
So or if the patient has pulmonary arterial hypertension, so all this is important because of all these factors.
Yes.
So though we mention it as a routine, we should always think, suppose respiratory rate. Again, respiratory rate is important in scleroderma and dermatomyositis because of failure and pH.
Yes, ma'am.
Right? So all this you have to keep in mind. Why? You see, it is not so important while presenting, but when you are seeing a patient on your own outside, each of these findings should arouse suspicion to check. That is the most important relevance. Why we ask also is because when you are practicing alone, all this should matter to you in terms of what you are going to do. Because sometimes your patient outside has very limited say money to do investigations. So which important thing you will choose to do?
Yes.
To decide all that, these little things are important. They help you.
Yes.
Yeah, go ahead. Puneet, you want to ask anything?
No, ma'am.
Okay, go ahead.
On general examination, the alopecia for the patient was present. Ptosis was present in the right eye more than the left eye. Oral ulcerations were present. In skin examination, skin thickening around the face and the neck was present. Erythematous macular rash, painless, non-pruritic over the nape of the neck and chest, which is more indicative of the V sign. Erythematous papular rash over the extensor aspect of the NCP, which indicative of Gauton's papules, and skin thickening over the hands, and sclerodactyly was present. In articular examination, no tenderness or synovitis was present. Incomplete closure of the fish was present due to the sclerodactyly.
Was there any digital pitting there?
No, sir. No digital pitting scars ulcers.
Okay, and was Raynaud's there?
No, sir. Reynolds was.
Now, how do you check for Raynaud's? Like in Indian patients, it's very difficult to check, no? You may not get typical, no, finding Raynaud's. So how will you check?
Sir, we should either ask for a history or we should immerse the hands in cold water in the clinic, and then we can check the immediate cyanosis of the patient. And the bluish discoloration of the fingers of the patient.
in a clinic to put hand in cold water and all will be time consuming. So how will you check? Subtle sign. You'll find the periphery cold. So you will find the middle or
Peripheral cold. Yes.
yeah, the periphery will be cold compared to the proximal part.
Yes.
Okay.
CNS examination, the eye motor functions were normal. Cranial nerves were normal. In motor examination, nutrition and tone was normal. Power in the muscles of the shoulders and the elbows were 2/5. The wrist, power of the wrist flexors and extensors were normal. Power of the hip and knees were 3/5. The ankles, plantar flexion and dorsiflexion were both 5/5. The MMT8 score for the patient was 37/80 or bilaterally 71/150. The modified Rodnan skin score was 29.
How do you assess modified Rodnans?
Ma'am, we have to check the thickness of the skin over the fingers, forearms, arms, chest, abdomen, face, feet, legs, and thighs.
Okay.
On pulling of the skin, the ability of the skin to extend or stretch, we identify Rodnan skin score according to that. It can be scored from 1 to 3, 0 to 3, 0 being normal, 1 being mild, 2 being moderate, and 3 being severe, which is no ability to stretch the skin.
Okay. Yeah, go ahead.
The superficial and deep reflexes were normal. Plantars were flexor. No sensory abnormalities were present. Cerebellar signs were no nystagmus was present. The rest of the cerebellar signs could not be elicited since the patient was in a wheelchair. Spine examination and speech examination were normal. No meningeal signs present. The rest of the systemic examination was normal.
Okay, so what you had thought of scleroderma with dermatomyositis on history.
Yes, ma'am.
Did it confirm on examination?
Yes, ma'am. With the proximal muscle weakness, along with the typical rashes along the knuckles and the chest, along with the skin tightening on the Rodnan skin score as well as on examination, and sclerodactyly.
Which you would like to see why it was there in addition?
Yes, ma'am. I couldn't get the question.
Anything odd in examination?
Ma'am, the ptosis has not been explained in the examination, why there is unequal ptosis of both the eyes, but it can be due to the skin tightening around the face that the ptosis has occurred.
Does the skin tightening cause ptosis?
No, ma'am, but in this specific patient, the ptosis was unexplained, but if the muscles of the eyelid, if they undergo scleroderma, in that case, the inability to retract the eyelid may cause ptosis.
Okay, it's okay. You can just say it was unexplained. Don't try to explain it because then the examination, I can chew you more on ptosis then. So don't do that. Anyway, apart from that, is alopecia expected?
Yes, ma'am. In patients of connective tissue disorders, alopecia is most likely expected of the tenogen effluent variety.
Alopecia is generalized hair loss or localized?
Ma'am, in scleroderma, the generalized hair loss over the skin is expected, but alopecia can be present in any connective tissue disorders, long-standing connective tissue disorders.
No, so generalized hair loss can happen in any kind of connective tissue disorders. If you are specifically talking of alopecia areata, you are possibly indicating something like lupus or a overlap. or mixed connective tissue, something like that. So when you say alopecia, you should specify.
Yes, sir.
Okay, yeah, you can go ahead.
And did you look for any calcinosis?
Yes, sir. No calcinosis was present overall over the body, as well as in the history also the patient did not complain of any swelling or bumps in the entire body, which were painful or hard. On examination also, so there were no calcinosis present.
Okay.
You mentioned sclerodactyly. Was there a you showed the modified rodents. Fine, no problem.
So, ma'am, after the history and the examination, I would like to give my diagnosis as a 38-year-old female with bilateral symmetrical proximal muscle weakness in the upper limb and lower limb without any sensory or bowel bladder involvement, with dermatomyositis like rash, which with a V sign, Scholl sign, Gottron sign, and heliotrope sign with sclerodactyly, with both eyes ptosis. My diagnosis would be overlap connective tissue disorder with features of dermatomyositis and primary systemic sclerosis of the limited variety, type 2.
You are saying overlap and you are saying primary systemic sclerosis. How does it match?
Dermatomyositis with systemic sclerosis, limited type 2.
Yeah. Okay. Yeah.
But
okay.
limited, but you're saying extensive, you know?
Yeah.
MRSS is very
Correct.
extensive, 29.
हाँ,
वो match नहीं हो रहा है.
sir, the maximum skin thickness was over the arms and the fingers only of the upper limb and the lower limb, along with the face. So the abdomen, chest, back wasn't involved on initial examination.
Dr. Kalk, ma'am, you agree with this?
Sorry, I missed it. What was it?
Ma'am, do you agree that this is just a limited sclerodoma? Or you think
No,
it'll
it
be
is
different?
not limited because he mentioned skin core was 37.
Yeah, which is correct. Okay. What is a very important family history in patients with dermatomyositis that you must always ask, which I think you have not asked? Family history of malignancies. So she's young. But,
Malignancies, yes.
this is a very, very important family history you must ask. Okay.
Especially when you are saying 10 kg weight loss.
Absolutely. Yes, ma'am.
Then, ma'am, on investigations before the presentation, in 2018, due to her history of 2 abortions in the first trimester, the lupus anticoagulant screening was done, which was negative. Initially, the patient was suspected of myasthenia gravis due to the partial ptosis of both the eyes, for which the acetylcholine receptor antibodies were done, which was negative. The eyes test was negative, and repeated nerve stimulation test was negative with no decremental response. The ANA West blot at that time came out to be C and P beta borderline positive. The skin biopsy of the eyelid was done in 2019, which showed sparse superficial and mid-perivascular lymphocytic infiltrates with scant mucin in upper reticular dermis. The epidermis showed mild irregular hypoplasia and focal interface, which was suggestive of either dermatomyositis or lupus erythematosus.
How will you differentiate clinically between skin rash of dermatomyositis and lupus?
Ma'am, dermatomyositis is an erythematous foliaceous rash around one or both of the eyelids of the eyes. entirely. The lupus rash will be more discoid in nature with hyperpigmentation, and might or might not cause scarring, whereas this rash will never cause scarring.
Will you be able to differentiate from what you are saying when you are seeing the patient?
Yes, ma'am. There was no scarring present, as well as
The
the
early
rash
lupus
was.
rash will have scarring.
Yes, ma'am.
See, the
I'm
most
sorry.
important thing clinical differentiation between dermatomyositis and lupus rash is lupus rash. When you say butterfly rash, it does not cross the
Yes, ma'am. It's not.
nasolabial folds, whereas dermatomyositis rash will not be restricted like that.
Yes, ma'am.
Yeah. Yeah, you can go on.
On the investigations after the presentation, the patient had slight anemia of 10.5, of HB 10.5 with a TLC count of 5,500, with ESR of 45 mm4 at the first hour with Westergreen method. CRP was 3 mg per liter. Rheumatoid factor was negative. CPK on presentation was 179. The rest of the reports of renal function test as well as the kidney function test and LFTs were normal. The
Why
SGOT was
rheumatoid factor done?
yes, ma'am.
Why was the rheumatoid factor done?
Ma'am, as a routine screening as well as to rule out whether
You are
it can
not
be
suspecting
MC,
rheumatoid, will you
MC.
do it routinely?
Yes, ma'am. The incomplete closure of the fist was also present, so
What
we
is
just
it?
wanted to incomplete closure of the fist, ma'am.
Yeah, but that can happen with scleroderma tendon related issues, na? Skin related and tendon
Yes, ma'am.
related issues. Why
Yes,
are
ma'am.
you? What are you trying to prove by doing rheumatoid factor? If you are doing a test, any test, even CBC, you need a justification.
Yes, ma'am.
You can't do it because it is routine. So
And ma'am,
there is an answer, but you have to give me that answer.
yes, ma'am. The also to rule out the chance of rheumatoid arthritis in case of MCTD patients.
So don't say rheumatoid. Okay, understood. Okay.
Doctor, I just wanted to ask you, was that do you expect this patient to MCTD with such severe myopathy?
No,
Patient
sir,
coming on
but
wheelchair.
no, sir, we don't with such severe myopathy, but it was one of the possible differentials.
So, but why do you need rheumatoid factor for that? You'll do which test you'll do will tell you whether that is there or not there.
ACCP, sir.
No, I'm talking about MCTD, no? You're saying you are suspecting MCTD, that's why you did the
Myositis
rheumatoid
profile.
factor, correct?
Yes, sir, myositis profile.
So
What in AMA?
which is a specific antibody for MCTD, criteria for MCTD? You're saying you want to load MCTD, but so why will you do rheumatoid factor? That doesn't add up. So which is the antibody that you look for MCTD, which is then the diagnostic criteria, without which you cannot diagnose
So
MCTD?
the U1SNRNP.
Yeah, so that you do that, no? Why will you do rheumatoid factor? Okay. Okay.
So after the investigations, the
Why
patient was.
HGPT is important, Dr. Mane? Why did
Yes,
you
ma'am.
do HGPT, SGOT?
Ma'am, in cases of inflammatory myositis, the SGOT or PT can be raised along with the CPK levels, aldolase, and the LDH levels.
Okay. What else?
Uh,
If you are not worried about this, would you do SGOT PT? Anyway, CPK is raised. So why do you need to do no SGPT, SGOT, SGPT? What additional information it gives you?
Ma'am, regarding the liver enzymes, if they are raised, any
So what additional information are you getting? You are saying it is because of the muscle that SGOT, SGPT will be raised. So,
Yes, ma'am.
so big deal if it is raised. You already know there is a muscle involvement. Does it give you any other information?
No, ma'am. Apart from the liver condition, I'm not sure whether it was.
So it is also important when you are starting on medication, you also want to know.
Pre-medical checkup, yes, ma'am. The systems.
So, and also whether it is coming down as you go, na? On steroids, it comes down, or sometimes this autoimmune condition can also have autoimmune hepatitis.
Yes, ma'am.
So you will do it as a baseline anyway.
Yes, ma'am.
Yeah. Yeah.
So on the first day of arrival, the patient was started on methylprednisolone, which is 1 mg per kg dose, oral dose, along with injectable methotrexate 15 mg, with oral methotrexate of 5 mg per week, with other supporting medications awaiting ANA West blot results, and planned for biologics and rituximab at that time. The follow-up was done after 7 days, in which the lower limb weakness was reduced. The relatives followed up after 7 days, after which the lower limb weakness was reduced. The biological screen came out to be negative, apart from the TB Gold test, which came out positive, and isoniazid was started for it. The 2D echo was normal without any pulmonary artery hypertension. ANA West blot came out to be positive for SSA RO52. A myositis profile was also sent, which came out to be PMSCL positive along with RO52 positive. Prednisolone was continued at 48 mg per day, and azathioprine at 50 mg, half tablet a day, along with the ongoing methotrexate dose.
Why was the azathioprine added?
Ma'am, in patients of overlap syndromes, since along with the methotrexate also the relatives said the weakness was reduced, but it wasn't that significant.
So why
azathioprine
not
was added
increase
as
methotrexate?
Yes, sir. So, ma'am, because we were planning to reduce the prednisolone later on, so as a steroid
No, my
sparing drug.
question is why not increase methotrexate? You can go up to 25
We
milligrams.
could have, yes, ma'am.
Then why after 15 you want to add azathioprine?
Just secondary steroid sparing.
Are there any risk in adding methotrexate and azathioprine together?
No, ma'am. Apart from the immunosuppression and the bone marrow suppression.
Correct. The most important risk when you add azathioprine and methotrexate is a bone marrow suppression.
Yes.
Yes,
So
ma'am.
in fact, by choice, you don't add them together unless you are pushed to wall. So
Yes.
according to me, I don't know why it was done. There may have been other justification, but unless you give one dose full time, for some reason, if patient is not tolerating methotrexate and not affording, and you were already planning rituximab,
Yes,
so
ma'am.
then adding azathioprine, at least you have not given us a justification to add. What do you feel, Puneet?
Ma'am, agree, ma'am. Absolutely. I think this combination is not, I don't think, a good combination. In resistant cases, they one may add methotrexate and CNIs. That has been used because, but this way, I don't agree actually. And also, I think Dr. Mane, How do you come to decision of giving methotrexate or any other treatment in a patient of this overlap syndrome and myositis? What information is needed before deciding what treatment you will give this patient?
Mm.
How
So
will you
I didn't get
decide
the
that
question.
how will you decide to give a patient methotrexate, azathioprine, or MMF or rituximab? What will decide your the treatment plan?
So
Is there
the
is there organ involvement that will be important to know?
Yes, ma'am. Yes, sir. The severity of the disease as well as the organ involvement or
So
the severity
when
of
we
the
look at
muscle
MMF,
weakness.
when we look at MMF and
MMF is given more in patients of ILD, sir.
who have
Or
so basically, yeah, so that part has to be discussed. Okay, on evaluation, on examination, you may miss ILD,
mm,
or an X-ray also may miss. So it also depends on the organ involvement. So at least a
uh,
lung function test if a patient not affording, but
hmm,
otherwise we miss ILDs also lung function test also. So in patients of dermatomyositis, especially when they have if they have scleroderma also, then maybe looking at ILD also is important.
yes, sir. So since the patient didn't have any complaints of uh, breathlessness as well as the
Then
chest
so what?
activity of
But
the normal.
that is that doesn't mean we don't evaluate for that.
Yes,
And then the treatment will depend upon the organ involvement also. If there's ILD, and you'll prefer giving MMF. If not at all affording, then one may consider azathioprine also. That will take care of the ILD as well as the muscle. Or you can then get rituximab, which again takes care of both. In patients who have predominantly only myositis, then methotrexate is a good option.
yes.
So for skin, which works better, Dr. Mani?
MMF, ma'am.
So if you
So
wanted to add methotrexate, why not add methotrexate? Something why not MMF? Why azathioprine?
ma'am, the more severe involvement was of the muscle weakness at that time.
So doesn't
Uh,
MMF work for the muscle? Does azathioprine work better for the muscle than MMF?
no, sir. No, ma'am, but the side effects of immunosuppression would have been uh, more, as well as it is more expensive for the patient.
The only reason is it is more expensive. Side effects are not more. Okay, are you worried about giving prednisolone to this patient?
Yes, ma'am, it will increase the chance of scleroderma renal crisis.
So
In
how
this,
long will you give
uh,
steroids?
yes, ma'am.
How long would you want to give steroids in this patient?
Ma'am, as a shorter duration as possible, but this high dose patient should be given for less than a month.
Okay.
I'm considering the lower limb weakness, which was very significant and debilitating at that time. We preferred giving prednisolone while planning for
So you have
rituximab.
planned rituximab. So
Yes,
was
ma'am.
the rituximab given when you added azathioprine?
No, ma'am. We had planned for rituximab, but since the patient followed up after 7 days, sorry, the relative followed up after 7 days with uh, he said that the weakness were reduced. We plan to uh, wait and see
So
if the
you
patient
added
responds on.
azathioprine on 7 days after methotrexate.
Yes, ma'am. The patient was already, when he presented to us, he came from a outside OPD where his treatment was already ongoing.
So what was
So,
that? Methotrexate 15 milligram.
no, ma'am. At that time, it was MMF, which he took for 1 month. Then he stopped. Then this time he started on methotrexate.
You started on methotrexate, na?
Yes, ma'am.
So how many weeks would you even consider increasing dose of methotrexate? How long does it take for methotrexate to work
Mm.
before you consider increasing the dose and
1 month,
worsening side effects?
ma'am. 1 month, 1 month to 2 months, 1 to 2 months.
Correct. So then why would you add azathioprine in 7 days? Anyway, just go ahead.
Then later in April, the patient followed up with increased lower limb weakness of MMT8 score of 31 by 80, with the other lab reports within normal limits. We advised the patient for immediate admission and rituximab at that time. The skin and muscle biopsy were planned to confirm the diagnosis, and PET scan was scheduled to rule out any malignancies. After the PET scan was done, it showed an FDG-avid cavitary lesion in the upper lobe of the left lung, which was suspected to be the primary malignancy. The skin biopsy and muscle biopsy was done later on, which showed atrophied epidermis. The skin biopsy of the hand showed atrophied epidermis with mild keratosis, sparse perivascular dermal inflammation. Dermis showed focally increased collagenous sclerosis with appendigeal atrophy and loss of periadnexal fat. The muscle biopsy of the thigh showed several thin angulated atrophic muscle fibers with clustering of nuclei, few scattered eosinophilic degenerating fibers, noted with centralization of nuclei with occasional regenerating myofibers, few hypertrophied muscle fibers with increasing endomysial connective tissue, fatty replacement of the muscle fibers, and increased endomysial perivascular inflammatory infiltrates composed of few plasma cells and histocytes. So this confirmed the diagnosis of scleroderma as well as dermatomyositis. And
Dr. Mane,
yes, sir.
why?
Yes, sir.
Do you know the Peter-Bowen criteria for dermatomyositis?
I'm sorry, sir.
Do you know the Peter-Bowen criteria for
Yes, sir.
dermatomyositis?
Yes, sir.
Yeah. So what is the criteria? Can you tell me?
So the criteria consists of 5 points. The first is the proximal muscle weakness. Then it is elevated inflammatory enzyme levels, which is CPK, SGOT, aldolase, or LDH. Then there is a muscle biopsy, which came to be EMG or imaging studies. EMG. And then there is rashes, skin rashes, which is typical of dermatomyositis.
Okay.
So
EMG was done for this patient?
No, sir.
So basically, see, in a patient with dermatomyositis, you don't need to do you don't need to do muscle biopsy because
Yes,
you can diagnose it without a muscle biopsy. If you have
yes,
the
sir.
typical rash, then why was muscle biopsy done? How is it going to change your treatment?
So, sir, since the patient has been on treatment for a long time with the typical presentation of the ptosis and not responding to medications, we just wanted to confirm it with a muscle biopsy because it was never done previously.
I don't
How
know.
does it help you with the ptosis?
I don't know. Ptosis is a different thing altogether, na? The acetylcholine receptors and all that was evaluated.
Yes, sir. It was evaluated. It came out to be negative.
But why was the doubt in the diagnosis?
With the non-responding to treatment since a long time.
But was the patient given appropriate proper doses of treatment before?
Yes, sir. Sorry, even though he was lost to follow up multiple times in the middle, but he was given for the year and a half, he was given appropriate doses, but it never showed any improvement.
MMF was given. How do you give 500 BD?
Yes, sir. 500 BD.
So that's not the
Later on,
dose,
he
no?
doesn't have the papers, but the medication was followed up with a rheumatologist for 1.5 years.
No. But was the appropriate dose given? The dose at least is 2 grams per day. So was that dose given?
Yes, sir.
And the non-responder, and you tell me a non-responder, the other cause will be what? The patient, I mean, now has come after many years and is not responding. CPK is not much elevated. So why is the patient not responding? What is the other reason?
The malignancies can be one of the reasons.
Right, correct. So the malignancy is one thing, but it can also be because of fatty change. Okay, you're treating more damage now than active myositis. So what is the investigation that will help you for that?
MRI, sir.
MRI. So what was MRI done?
No, sir, MRI for the patient was not done at the time.
Right. Okay. I think, ma'am, and this cavity
So are
lesion,
the
what was,
investigation over?
No, no, ma'am. I just have a couple of slides left.
Okay.
Then, with the suspicion of primary malignancy, a chest physician was consulted. Bronchoscopy was done, which showed normal mucosa apart from some inflamed mucosa near the apical bronchus. The bronchoalveolar lavage was sent for AFB fungal stain, Zn stain, Gram stain, which came out to be negative, along with the gene expert, which came out to be negative. Cytology showed no malignant cells. Awaiting cultures, the patient was continued on prednisolone with a tapering dose. Methotrexate was stopped, and azathioprine and MMF 1 gram BD was started, along with rifampicin on the chest physician's opinion.
Why? Because you are suspecting TB.
TB, yes, ma'am. Because initially the TB gold was positive, but the entire bronchoalveolar
But treatment
lavage
you
came
are
out to be
given
negative.
of only latent TB.
one
Yes,
single
sir.
drug is
Yes,
given.
ma'am. So we had consulted with the chest physician also. He didn't suspect any overt signs of TB, or he wasn't convinced that the patient had an
Correct. So
active
then
TB
you
at
are
that time.
treating
So,
latent TB. Then why did you change methotrexate to azathioprine and mycophenolate?
ma'am, the change was because now we are suspecting malignancy, so we couldn't go on with the uh,
But malignancy was ruled out, no?
rituximab. No, ma'am, the chest physician wasn't convinced with that it wasn't a malignancy. They were confused between latent TB and malignancy. So this was a precautionary uh, prophylactic dose was given of rifampicin and isoniazid, but still we withheld rituximab because we were suspecting malignancy at that time.
So why didn't you all do a CT scatter biopsy then? If bronchoscopy was not conclusive and you suspected malignancy, because you can't.
So we insisted on the chest physician doing a biopsy, but he was not convinced that the biopsy was needed right now, as he was sure the bronchoscopy was sufficient.
But
So we were,
you are contradicting. You're saying that the chest physician felt this is malignancy, but the bronchoscopy histopath did not show malignancy, but he's still suspecting malignancy. So then you have to go
yes,
to the logical conclusion, no? Then
yes, so he was so suspecting malignancy versus TB, any of the two, but he said biopsy right now was not required. We were planned for further investigations for the same. So we were in consultation with the chest physician the entire time. So we wanted to do a biopsy, but it was his opinion to not do the same.
Okay.
I didn't. I don't know. That's not making sense.
Something is missing.
Yeah.
Yes, ma'am. Ma'am, that's why we wanted to do a biopsy on our own. We insisted on the chest physician several times, but in his expert opinion, he didn't consider biopsy to be of the absolute importance right now. He
No,
was
means
convinced that this was.
according to me, if he did not think biopsy was important, that means he is not thinking of malignancy. You can't be thinking of malignancy and not do biopsy. It doesn't match
Absolutely.
in our head.
Yeah,
So,
absolutely.
And especially a patient who is so sick and you need to give other medications and steroids, you can't be waiting and sitting on a patient thinking of malignancy, no? Either you do it or you say it is not there, is the way we are thinking. There may be some
Yes,
other
ma'am.
reason why he didn't want to do it and he has not told you, but this is then you are left, you are treating half-heartedly. Anyway, you go ahead. It's not your fault, so you go ahead.
So, ma'am, after a couple of months, the improvement in the lower limb weakness was noticed with an MMT score of 35 by 80. The AFB fungal and AFB culture and fungal culture was negative. The case was discussed with the physician, and prednisolone was tapered along with MMF 1 mg BD was continued. Since we were still suspecting of malignancy, CA 19.9 and CA 125 was sent, which came out to be negative. And HRCT was later done in June, which showed a thin-walled cavity with surrounding fibrotic changes in apico-posterior segment of the left upper lobe, suggestive of sequelae of fold infection. Several fatty infiltration and atrophy of all visualized skeletal muscles was also present, which suggested of dermatomyositis.
This is exactly what Dr. Puneet was trying to tell you.
Yes, ma'am.
Also, in your treatment, something is missing. When you give this high dose of steroids with mycophenolate mofetil, so which is supportive medicine that you give? Can you elaborate, please?
So, supportive medications is I'm sorry, I didn't quite get the question.
What is you have mentioned there, mycophenolate and steroids with supportive medicine. So can you please elaborate the supportive medicine?
For folic acid, iron, calcium, vitamin D3, these are primarily given.
You will give iron even if the patient is not iron deficient?
No, ma'am, folic acid primarily.
Why folic acid?
Initially he was given initially the supportive medication when the patient was on
So every
methotrexate that
patient
time.
you give folic acid?
Yes, ma'am.
Every patient you will go give folic acid as a supportive medication?
Ma'am, for with methotrexate, yes.
Yeah, but you have to stop methotrexate.
Ma'am, during methotrexate, folic acid was given. Right now, it was just calcium, vitamin D3.
So, anything else Dr. Puneet is asking you?
With high dose steroids, with immunosuppression, you'll give PCP prophylaxis, no? Septran prophylaxis you'll give, no? And it not only protects on the PCP, but also other opportunistic infection like nocardia, other infections. So very important to give.
Yes.
Yeah. Take it.
So after the HRCT, once the confirmation was done, we started with the first dose of rituximab. The second dose was given after 15 days. And post the dose, prednisolone was reduced to 32 mg per day along with tapering dose. The latest patient follow-up was on 13th of August with improved lower limb weakness. The patient could walk without support with an MMT8 score of 52 by 80 with a modified Rodnan skin score of 27. Prednisolone was reduced to 30 mg per day with a tapering dose, and MMF is still started on 1 gram BD per day along with other supportive medication.
What is the dose of rituximab you give?
We have given 500 mg, ma'am. It's a low dose. No,
what is the dose?
1 gram, ma'am.
1 gram? Total?
Yes, ma'am.
1 gram total?
So 1 gram initial dose, then after 15 days we give the second dose of rituximab, and then again after 6 months we give the third dose.
Any reason why you gave the less with such a severe disease? Can you give a lower dose?
And for a less severe disease, we can, ma'am.
What disease?
If the severity of the disease is lower, we can give 500 mg.
No, I didn't get you. Sorry.
Ma'am, if the disease severity is just mild uh, or any other limitations are present, then we give 500 mg. But then it was
Were
decided
there
by
any
the
limitations in this case?
no, sir. No, ma'am.
Will it depend on the weight of the patient?
Yes, ma'am. The weight was 48 mg of the
Yeah,
patient.
I know in this patient, but was it a less weight? That's why you gave less dose.
Yes, ma'am. Because of the
Don't say, don't. I'm just teasing you, so don't put your foot into it. Okay, what is the dose nephrologists give normally for rituximab?
ma'am, the 750 mg is given for the lupus protocol per month.
No, nephrology dose is weekly dose of rituximab, and they have a proper dose per meter square.
375 mg per meter square.
Correct, correct, correct. Okay. So you have finished presenting, or is there anything you want to present?
No, ma'am. This was the last follow-up of the patient in which the patient is improving with MMT score of 52 by 80 right now.
So, Dr. Mane, if the patient had some infection, the cavity was some infection like TB, then how would you manage the patient? And if finance is not a problem,
Yes,
what is the
ma'am.
safest?
So,
What is the safest treatment to give?
sir, if TB was active, we would give the full dose of anti-tubercular drugs
Yeah, that is
initially,
okay.
and
For the disease, I'm asking. For the disease, what you will give? Which is safest? Which is very expensive, which is but safe.
IVIG.
IVIG, very good. So, what dose
Yeah.
will you give IVIG? What is the protocol for myositis?
Mm,
Like you give 2 grams per kg per day.
Not really.
2 grams per kg. That's a loading dose, and then after that, every 3 weeks you give half the dose.
Okay, sir.
Yeah. But I think in this patient, I would have done MRI muscle also to look at how much of active inflammation is there or fatty changes there, especially once they plateau. Because then we should know the level of immunosuppression, especially if the CPK is not elevated. Here, there is no information about the CPK actually values that you have said
Yes, sir.
power is improved, but you should also mention what is the CPK. And if they are plateauing, then I think do an MRI and we should give the full dose of rituximab.
Yes. So the CPK values were on the lower or the slightly higher range or within normal limits since the beginning of the patient presentation, since the patient was already on high dose of steroids since a month before presentation.
All the more reason that you need to see how much is the inflammation. No?
Yes, ma'am.
Correct. Also, sometimes scleroderma, they have a blind myopathy also. That also is important to keep in mind. So this is the overlap of PMSCL overlap, but other scleroderma can have a blind myopathy also.
Yes.
Okay, good, Dr. Mane. Anything else you want to ask, Puneet?
No, ma'am. Thank you.
Dr. Mane, you presented well. See, though we both will sound like we are trying to grill you, which we are in a way, but the importance of this is so that even, see, Dr. V.R. Joshi used to always say that every clinical finding and every investigation, whatever you do has to be justified. So the whole idea of grilling you is to make you think so that when one thing is when you present in the exam, the examiner is going to ask you similar kind of question, but that is very short term. But as a long term, to train you to be a good clinician, you should ask even your seniors, if you felt the rituximab dose was low, you cannot change, but your senior must have some justification for giving that dose, or you should be able to question, why this, why azathioprine, why not this, why did we do this, why not we are doing this. So once you are a qualified physician, it is your right to also ask questions and learn. And we all learn, all throughout the life, on every case, we all are learning. So especially when you are under someone, believe me, when you go in practice and start taking decisions on your own, all these little things will start bothering you. And then you will remember your senior thinking, oh God, what would have they done? How they would have thought? Why this didn't occur to me when I saw that patient? So you should try to learn as much. That will not still reduce anything further, but at least it will make you think on each thing everywhere, and the chances of you missing out and making a wrong diagnosis will be less. So every clinical little indication is pointing and trying to tell you something. So the whole idea is to make you, look at everything again and again to see, okay, why did I do this? Why did I do that? What will I do if this happens? What will I do if that happens? So the whole idea is to make you think. Anything you want to add, Puneet?
No, ma'am. Yeah, I think this grilling is nothing personal. It is just to make you learn. That's all.
We all have gone through this. We all have made mistakes. So don't think that we have been there and done that. It's not like that. But you have to learn to understand and learn to interpret everything so that you can become a better clinician every day. This is everyday process.
Yes, ma'am.
Yeah. So good. Unfortunately, because of the unforeseen circumstances in Kolkata, Dr. Alakendu Ghosh is not able to join today. So that's why we could, though we were late to start, we could continue a little longer to complete the case. Dr. Ghosh will not be there, so we'll close the meeting here. Thank you, everyone, and thank you, Dr. Mane, and all the best to you.
Thank you, ma'am.
All the best. All the best.